Hello, good morning. Hello, everybody. Dear colleagues, it's my real pleasure to warmly welcome you all today to this wonderful session, which has been organized together by UFA office and by Gamian. Unfortunately, one of the speakers, Helen Bennett, is not able to make it today. However, we have great speakers across the panel, and I would like to express a big thank you to the organizing team, who are behind the curtains, and a big thank you to all the speakers which we have today. This event is planned during the European Public Health Week. I'm Jutta Lindert, I'm Vice President of the UFA Public Mental Health Section. UFA itself is an umbrella organization for public health associations and institutes in Europe. UFA has currently 80 members from 47 countries. UFA has 26 sections, which are international networks where experts on specific themes share their knowledge with each other. Today, we have the public mental health section represented. And the motto of this year's European Public Health Week is Join Forces to Healthier Population. The aim is to raise awareness about 5 important public health themes, each year anew, and to promote collaborations among the public health community, from local to the European level. This year, we are lucky to have more than 20 events hosted by 40 countries in 19 languages. The themes of today are communicating science and health, today new challenges in mental health, tomorrow your local community, on Thursday all for one health, and on Friday a huge theme, leaving no one behind. Today our topic is mental health and public mental health. The loss of loved ones, death and loneliness caused by COVID have aggravated mental health problems not only in Europe but worldwide. How can we respond to the needs of people better? How can we care? And how can we build back better? So far, we are not aware what is the state of public mental health in Europe. Why is it important? Approaches to addressing mental health so far have often focused on medical services to individuals, not on fostering conditions that promote mental health or primary prevention. Clinical services and clinical mental services, of course, dramatically improved the lives of many people. But it became apparent that the provision of clinical services alone is a suboptimal approach to maximizing the mental health of populations. Why is it important? The pandemic has tested us in unprecedented ways. Behavior and social context changed while COVID swept across the world. However, mental disorders and people with mental disorders often have been neglected. And as well, public health for many years did not recognize how important mental health is. This has changed in the recent years due to the efforts by the World Health Organization, the European Commission, the European Public Health Association, and of course Gamian. Let us remember, what are mental disorders? Mental disorders are mainly syndromes characterized by clinically significant disturbances in an individual's cognition, emotion regulation, or behavior that reflects a dysfunctional to psychological, biological, or developmental processes underlying mental functioning. Already before the pandemic, the burden of mental disorders was among the most prevalent ones across the world. Almost 16% of the world's population were suffering from mental disorders. This accounts to almost 150 million people, which means that this, according to the Global Burden of Disease study, disability-adjusted life years really accounted mainly to mental and substance use disorders, and here we have some figures adjusted for age. However, it's not so necessary to read all the numbers, but it is a nice way to remember us that mental disorders really represent a huge part of the burden of disease worldwide. However, this is different across age groups, and the age group which is often mostly affected are the younger ones, as we know that many mental disorders already start at young age, mainly between 15 to 25. However, as well in later years, there is a huge burden of mental disorders with slightly changing disorders, and up to the older population, Alzheimer's diseases and other dementias take over a huge part of the burden. However, these disorders are not serious and persistent always, but only a minor part is a serious and persistent condition. Nevertheless, many people are affected. One time in their life, at least 1 in 3 persons worldwide is affected by any type of mental condition. This means we have really a public health condition when we are speaking about mental health and mental disorders. On the other hand, what is mental health? Mental health has been defined as a state of well-being in which every individual realizes his or her own potential, can cope with normal stresses of life, and can work productively and fruitfully. Which means that there are some characteristics which characterize mental health, such as the ability to adapt to changing environments and to changing events. Taken together, mental health and mental conditions manifest as a continuum, not as 2 separate categories. And if we look at the population mental health, we can see that mental disorders and mental health is distributed across the populations and across the world differently. So we have here a normal distribution, and the normal distribution is shaped according to the environments and according to the events. How is it shaped? What are the mechanisms of risk? The mechanisms of risk have been identified in an ecological scheme, which means that there are some risk mechanisms like social relationships, living conditions, neighborhood and communities, and finally societies and genetic and constitutional factors. So we know already quite a bit about the influencing factors, mainly about traumatic life events and about socioeconomic status and their linkages to mental conditions. We have some studies about the impact of maltreatment and violence in childhood on later life, depression and anxiety. And we have some knowledge on the impact of life events and mental health symptoms. And basically, it can be said that the number of life events is associated with an increased number of mental health conditions. So there might be quite a linear relationship. What does it mean during COVID? All of us suffered some traumatic events during the pandemic. All of us are affected, maybe affected by loss of lives of loved ones, by death, by the exposure to the virus, or by exposure to the virus of family members and loved ones. On the other hand, we know that social class and mental illness are closely linked, and social determinants account for a huge amount of mental conditions. Which means that during the pandemic, during the times we live in, the pandemic often opens default lines. The pandemic has the force and the power to change the distribution in the population, to change the distribution of mental conditions. Here, mental health might play a role in the future. Public mental health means that we account for the huge number of people which are affected by mental conditions, and we need to shift away from a focus on the individual mental health problems and include as well population mental health problems and population mental health conditions. Which means that public mental health can be defined as the science and art of promoting and protecting mental capital, mental health, emotional well-being, and preventing mental illness, prolonging life and the quality of life through the organized efforts of society. Here we take into account that mental health is multidimensional and can change over the life course. So the aim would be to integrate the psychiatric and medical services into a future picture of integrating medical and public mental health approaches and try to bring them together as a public mental health approach might be targeted whenever and wherever and is not restricted to fixed responses, and additional is focused on the population and not on the individuum. By integrating medical and public mental health interventions, we can integrate case identification, treatment, prevention and mental health promotion, and maintenance of positive mental health. This might contribute to changing the curve, to building back better, and to add to the devastating experiences we all had in the past year, other experiences which might contribute to promote positive mental health. Taken together, we know that mental health and mental disorders are shaped to a great extent by social and physical environment conditions. Improving these conditions from before birth, during early childhood, at school age, during family building and working ages will provide opportunities to improve population mental health and to reduce the risk of mental disorders. Our task, therefore, now is to respond and to care better, to contribute to a better public mental health system in the future. And herewith, before we come to the final remarks, it's my great pleasure to hand over to Dan Chisholm. He is a program manager at the World Health Organization for Mental Health in the WHO Regional Office for Europe, based in Copenhagen. Formerly, he was a health systems advisor in the Department of Mental Health and Substance Abuse at the WHO headquarters in Geneva. It's a great honor that you found time today, Dan, to contribute to our session. We are looking forward to your talk.
Great. Well, thank you very much indeed for the kind introduction, and congratulations for the event. Not just this one, but I was also delighted to see how many events are taking place across the European continent, East and Western Europe, today as part of the European Public Health Week. And it's good also to see mental health included again in the agenda as a priority concern and focus. So yes, I can spend a few minutes providing some perspective on the mental health impacts of the pandemic, and some reflections on some of the ways in which response and recovery efforts can be accelerated. So to start with, I will go straight to some of the key messages that I'd like to convey this morning. The first is just, as Jutta was saying, that everyone's mental health and well-being has been affected one way or another in the last year or more now. But of course, there are certain groups in society who are more vulnerable and have been more impacted. Not just people with existing or pre-existing mental or physical health conditions or disabilities, but a range of other groups ranging from from younger people right through to older adults and people living alone and with frailty. So that's point number one. The second is just talk about the impact that the pandemic has had on mental health services themselves. Both enormous disruptions, of course, particularly during the first acute phase, when everything was turned upside down and wards were, for example, converted into COVID wards. But also a range of new needs and demands quickly became very apparent. So we'll talk about that. And then the third point is more like a policy point, which is that the last year is very clearly demonstrated. We already knew, perhaps, but to others, perhaps it was less clear, but the need for mental health and psychosocial support to be a critical or core element of any emergency or humanitarian response and recovery effort. And this has been brought home by the scale and spread of this pandemic over the last year. So Jutta already gave some context to this about the situation, if you like, before COVID-19 hit. And just a few statistics here. The first one is that 100% of us need good mental health to flourish. There is no health without mental health. But unfortunately, around at least 1 in 10 of us and up to 1 in 5 of young people do experience mental health challenges or issues at any one time. And often those issues or problems are hidden, suffered in silence, and largely untreated, particularly the more common mental health conditions like depression or anxiety. Even in the higher resource countries, perhaps around 1/3 are effectively covered and receive appropriate care and support and treatment. But it's far, far less in the lower income countries of the European region. And not forgetting, of course, that also there is a huge loss of life due to suicide each year, more than 700,000 globally, and over about 120,000 in the European WHO European region. And not only is suicide a major cause of death, but we also have to remember that mental health conditions are also associated with excess mortality that is not just due to suicide. It's often because of neglected or untreated chronic diseases. So people with severe mental health conditions, for example, often stand to live 10 or even 20 years less than people without those conditions. Now, then the COVID-19 hit more than a year ago now, and some of the defined kind of consequences of that on mental health at population level are given here. This is outlined in a UN briefing on COVID and mental health. And you can see there's 4 listed there. So there's the actual direct effects of the disease on people's mental and neurological functioning. And that's become increasingly clear over the last year about the quite high prevalence of neurological and mental manifestations of the disease itself. But back in this time last year, the main impacts that we're seeing, of course, just the direct sort of fear and anxiety people had about this new virus and whether they're going to get it or someone they love who are going to get it. And then as the pandemic took hold, some of these other countermeasures, IPC, infection prevention and control measures, such as lockdown, school closures, isolation procedures, of course, all have their own separable impact on people's psychological well-being. And then now, of course, as the cumulative effects of these measures have led to enormous losses in economic output and in levels of debt and unemployment, impoverishment, and also increasing social inequalities. So this is shown here in this slide from the World Happiness Report, which sort of shows these kind of waves or separable kind of effects over time that we have seen. Let me go back up here. In terms of the mitigation measures, the 3 that are spoken of in this briefing paper include the adoption of a whole of society approach. This is, as Jutta was already saying, this is not just a health sector problem or a medical issue. This is a whole intersectoral issue that needs to face up to the many social and other determinants of our mental health and well-being. Second one is, of course, increased access to mental health and psychosocial support to those in need. And then also this point that also Jutta already made about the opportunity that's presented to build back better, a much used phrase, but it is very true that there is an opportunity to do things differently and hopefully better than were done in the past. Some of these key points are also embedded in this policy or this decision of the WHO Executive Board about the inclusion of mental health in public health emergencies. And this has been signed and proposed by all the member states of the European Union, as well as about 15 other countries. So this actually is now, will be going to the World Health Assembly in the next few days.
Dan, I'm afraid your time is over almost.
Okay, right, wow, time's gone. Let me just talk then about these impacts that have been looked at from the European Regional Office perspective. They set up a technical advisory group and they've looked at these 3 groupings, public mental health services and systems, vulnerable groups, and finally the kind of community and general population impact. So watch this space because they're in the process now of coming up with some policy options and recommendations for how countries can appropriately respond to that. So maybe then I will leave it there and pass it back to you, Jutta. And thanks very much for your attention.
Thank you very much, Dan, for these inspiring comments. We really should think more about it. And now it's time for Tomasz. And it's my great pleasure to introduce Tomasz. I think I cannot pronounce your last name, Sedowski.
Yes, you can use it, the US here, their CH, and you can pronounce it as K, also Zdekowski. It's much more useful, also you can use it. So
a big welcome to you, and we are very pleased that you found time in your busy schedule. Tomasz is a Czech politician, crisis manager, media analyst, poet, and author. He was elected as a member of the European Parliament in 2014 and re-elected in 2019. And since 2008, he is a member of the Christian Democratic Party in the Czech Republic, and in February he was elected as the deputy leader of this party. So we are really pleased to have you here, Tomasz. The floor is now yours.
Thank you very much for great interaction, Jutta, and thank you very much all of you for this excellent event. I think it's very necessary. You had it very good information about me, but I would like to add that before I was MEP, I focus on coaching of managers and athletes, and I was using neuroscience. Also, it was really the training for better performance of brain, and my part of my education is psychological education. Also, it's very important to add here. And when I came to the European Parliament in 2014, I wanted to focus on mental health and health and brain, also on a European level, because I see it's very necessary to speak about that, especially not only in these times, but continuously, because in many things we see huge progress, but especially in the mental health, we need much more pressure to the European Commission and to the member states to show how is it important. Also, to be co-chair of the Alliance for the Mental Health, it's for me very good opportunity to shows and to give my personal experience with this problematics to European level. And this is why I want for the future much more take action and pressure, not only for the European Commission and for the Council, but for the member states, where they have it, the money, and they don't use it in better way. And also it's very important. In the COVID time, my experience last 16 months, it's so that I was working in the hospital, in the COVID department. Then I was working in some house for this was the social services for people in pension. There was the COVID department too through the Christmas, and after them I was testing the people on COVID, and I did a lot of work, especially with the charity of the Czech Republics in their houses. I helped with this service because there was many people sick, and as a soldier reservist, I went in the front line to help the people, and I saw there is a lot of problems still ongoing. In the Czech Republic was the situation really disaster. I saw more than 50 people dies in these very short times, and especially for me, and my experience was so that I cannot sleep for 1 month, and I had some psychological problems in these times, because in a normal time in European Parliament you don't see them, and you don't have it the experience with death. And normally the COVID issue is so that in one day the people are laughing, they are trying jokes with you, especially women are laughing and saying that you are very handsome man, etc. In second day, they feel a little bit bad, and in the third day, I was the man who were taking these people to the black box and really catching their hands in the last 2-3 minutes. Also, it was very difficult, and I will tell you my personal experience that normally I'm strong and I don't have it fear for nothing, but after them I had it really problems, and I can tell you many the stories of nurses who would have it still the problems, or doctors, or people who were working in the hospitals or in the social area, and they saw in the short time really this disaster situation. And when I was working through the Christmas in this house for the people in pension, the situation was much more quicker, and this is something what I will remember all my life. This was like in war. Also, you was counting every day more and more people, and in this house, half of people dies in 2 months. Also, in very short period, really, the people went out of our life, and I think that it's necessary for the future speak about them. And if we are speaking about the European level, it's necessary really have it any strategy for the future, because it's not only about this pandemic, but it's much more about that people didn't have it space for any funeral, because everything was closed. There was not space to come there and speak together, and there was no one who was listening to these people. And I think that in this mental health strategy and in national mental health strategy, we have to put there more things about the COVID issues and about how to improve the psychological and mental health support for the people who are still in very bad psychological condition. And for the future, and I will close my remarks, I am prepared really with this experience to help all this initiative and to help the people what they had this problem, and they were facing someone who really passed away. And I think that we prepare now the project in the Czech Republic with charity of the Czech Republic. The name is that Hope will return, and I hope that we will collect more than 100 million of Czech crowns, and we will use it for the mental health issue. Also, I hope that really Hope will return back to our lives. Thank you very much, and I will be here with you to listen your remarks and your experience. Thank you very much for this experience.
Thank you very much, Thomas, for these moving experiences you shared with us. It's really necessary to remind that we are speaking about real people lives. So thank you so much for your talk. Now it's my great pleasure to present to you Eric van der Eycken. He is a research project officer of Gamian. By profession, Eric is an engineer, and additionally, Eric is an expert by experience with lived experience of bipolar disorder. He is also the EU project officer for Gamian Europe. So I'm so glad that you found time today to present to us what are your experiences with the past year. The floor is yours, Eric.
Thank you very much, Jutta, for this long introduction. I've never had this kind of long introduction, so many thanks. Good morning to everybody. Now, before exploring the impact of COVID-19 on patients and services, let me first short introduce the organization Gamian. And saying that, sorry, I just have a look if my slide is going down. Is my screen shared? Should be.
Yes, we can see your screen.
You can see. Okay, good. Now it should still. Okay, there you go. Okay, so introducing Gamian. At Gamian Europe, the core mission is, in fact, to give the patients a voice, patients who are living in mental health conditions. Gamian is a European umbrella patient organization with about 66 members of national organizations across 27 different European countries. Now, Gamian Europe makes sure that the patient's voice is heard at both national and EU level with respect to policy development. It ensures that good services are provided for those affected by mental health issues, and it coordinates also the European Parliament Alliance for Mental Health. This alliance brings together some 30 MEPs championing the development of mental health strategy. And via strong partnerships with different EU organizations in the area of health policy, Gamian joins forces to strengthen the voice of the patients and its carer. As you can imagine, last year kept us extremely busy and shed light on mental health issues in ways like never before. We recently launched the results of a survey we conducted. It was held between September and December 2020. It was a challenging year for all of us, all around the world. And for many of us, we wanted to know what the impact it had on people with pre-existing mental health conditions. So this online survey was sent to individuals via Gamian Europe member organizations. The questionnaire has been made available in 13 different languages in order to reach as many as possible persons across Europe. The survey gathered over 500 responses, and the full report, you can find it available on our website. During the next 15 to maximum 20 minutes, I'd like to present you some of the results by covering, in fact, 6 points related to this survey. The impact of the pandemic on mental health status. The first part of the survey looked at how the pandemic had affected patients' mental health. One of the key points we found is the worsening of the conditions for people already suffering from their mental health. Two specific situations became clear out of that. First, we had the worsening of the symptoms for people suffering with their mental health, at the onset of the pandemic. But secondly, we also had the reoccurrence of symptoms in people who were in remission at the onset of the pandemic. Over half of the respondents said that their mental health had become worse since the COVID-19 outbreak. And I think this is a quite high number. 57% of the respondents said that they had noticed some kind of change in the mood, most of the time describing mainly as a decline in their mood due to the pandemic. Additionally, we found, and it was already mentioned earlier in the presentation, we found that fear and helplessness were top of mind for many of the respondents. The lockdown and the medical crisis basically left people feeling scared and helpless. There is no better way of describing this by quoting one of the patient's open-ended answers of our survey. My depression has become worse because my daily routine has collapsed. There is a lack of social contacts. I'm not able to pursue my hobbies and my usual rehabilitation measures are more difficult to do. What can I say more? The fear of going outside was particularly notable because some respondents were concerned about the behavior of others who may not be following the rules to reduce the spread of the COVID-19 infections. This all was triggering their mental health symptoms. Social isolation and lack of routine also played, of course, an important role in the deterioration of the respondents' mental health. Access to mental health care during the pandemic. Regarding access to care, nearly 1 out of 5 respondents said they were not able to access mental health services when required. And this is again a high number. Even when people received mental health care, it was not always satisfactory. In fact, 1/3 of the respondents said their mental health care was not adequate. The reasons for not being able to access mental health care services were mainly due to fear of going to the treatment center, healthcare professionals that were not available, financial issues, and also digital exclusion was also cited as a reason for some respondents. We also found that 60% of the answers of the respondents saw a switch in how mental health care was delivered since the pandemic started. The biggest change, the biggest change being a switch to telephone or internet consultations. Of the 60% who said their ways of receiving mental health care had changed, 65% reported a switch to telephone consultations and 47% used the internet. This shows how face-to-face consultations and on-site visits to receive mental health care have been partially replaced by digital technology. However, from our survey, we cannot conclude that this way of healthcare was adequate enough. For some respondents, relying only on such digital communication was not enough, and highlighted that some face-to-face contact was still necessary. The sources of support for patients during the pandemic. Interestingly, family and friends were the biggest source of support for many patients seeking mental health care. More precisely, 85% of respondents said they received most of their support from their loved ones. This is quite encouraging that even in such difficult circumstances, the strength of the bond with family and friends is still so important to be a source of support. Although not quantified in our survey, self-help and peer support groups were another important source of support, as described by the respondents in their open-ended responses. Physical health. It is important to note that in our survey, 45% of the respondents had a pre-existing physical health problem. Of the respondents who reported having physical health problems, 1/3 said that their physical health had deteriorated during the outbreak, although for the majority this was not the case. But this kind of findings, I think, might explain why we observed such a strong negative impact of the pandemic on the mental health in our sample. The fear of contracting the virus was a particular concern, according to the responses of many respondents. It is important, therefore, that health services are aware of the need to ensure that physical health care for people with pre-existing mental health problems is provided in a timely way. To put all these results in the right perspective, it is of course important to see some key data about the respondents' profile. As you can see in the left graph, you can see that the respondents who completed their questionnaires in German, English, and Dutch are together more than 50%. But also the Portuguese, Croatian, and Hungarian language was relevant in this survey. Almost half, of 48% to be precisely, of the respondents were aged between 30 and 49 years. But younger and also older people took part in the survey. As you can see in these pictures, the percentage of the respondents living alone is about 27%. Compared to other surveys related to people with mental health problems, this figure seems slightly unusual and a little bit on the lower side. So with this respect, the sample or our survey may not be completely representative for persons with a pre-existing mental health problems. So we think that the effect of the social isolation could even be worse than we find via this survey. For the employment status, we have a similar slightly different percentage that it might be expected on other studies. With 40% of the respondents, the employment is a bit higher than found in other surveys. Some thoughts, some conclusions. Let me finish my presentation with a few thoughts. While the findings of our survey mainly highlight the negative impact of the pandemic during its first year on mental health, there were also some positives. Some respondents found lockdown gave them more time to relax and took them away from their usual daily pressures. 45% of the sample had pre-existing physical health issues. And despite many respondents not experiencing worse physical health, it is important to acknowledge that there is still a minority who did. Most of the respondents are somehow linked to, or they are a member of a patient or a national patient organization where they often can find support from peers. So from that point, we might have missed the people that do not have this kind of support. In summary, a few conclusions. The mental health impact on those people with pre-existing mental health problems, they show increased fear and anxiety, which is also confirmed by findings of other surveys and research studies. For most of the respondents, healthcare services was still accessible, partly by switching over to teleconsultation or internet-based service. But approximately out of 5 experienced a lack of access to the services, and 1 out of 3 had an inadequate healthcare service, mental or physical. Our survey revealed the importance of support from family, carers, and peer support groups, which has been even more critical during this pandemic. And what about the post-COVID-19 period? Hopefully this will come. Of course, it is vital for mental health services to continue monitoring and reaching out to patients who may be reluctant to access services for fear of contracting COVID-19. It is important to ensure that additional resources, both staff and extra funding, are provided to meet the increasing demand for mental health and general health services even after this pandemic. We should also make it easier for people to access e-health technologies, particularly people who might not be digitally savvy. This is an important goal and a good way to ensure continued access to mental health services, which is COVID-19 secure and safe. One thing we've noticed is that patients prefer a mix of both e-service and in-person service. Extra resources are also necessary to support organizations such as peer support, self-help groups, and carer organizations, who we know provide invaluable support to people with pre-existing mental health conditions. Not only mental health, but also physical health should be screened sufficiently for people with pre-existing mental health problems. With that respect, this group should be identified as a priority group for receiving COVID-19 related care, such as, for example, the COVID-19 vaccine. Thank you for listening, and also a thank you to Janssen Pharmaceuticals and Furrer Pharma, who have financially supported this survey without having any influence on analyzing these results. Thank you.
Thank you very much, Eric, for sharing with us these much needed data and for adding the perspective how important family support and peer support is for people living with mental conditions. So thank you very much again. Now it's my great pleasure to introduce to you and welcome Stefania the Majestic. Stefania is a social worker by profession. She holds a master's degree in European Studies, and she had many important positions at the Ministry for Social Policy of Malta before she moved on to be Chief Executive Officer at the Richmond Foundation, which is a leading NGO in the field of community mental health services provision. We are glad to have you here, Stefania. The floor is yours.
Thank you very much for that introduction and for the invitation to speak. It's an honor to be speaking together with so many other leading speakers. So I will be sharing with you the experience of Richmond Foundation as a mental health NGO over the COVID year. I will start off by giving you a bit of an insight about Richmond itself. So Richmond has a whole range of services varying between residents and other services to the public, both people who have an ongoing mental illness and people who are only just developing the first symptoms. So we have 7 group residences and 31 apartments, which accommodate 144 residents in all. These are their permanent accommodation. We have 95 corporate clients, so companies whose employees we support through therapy and psychological services, and also through training. In 1 year, we calculate that we work with 4,500 individuals. Just to put some context, the population in Malta is around 450,000. So that equates to around 1% of the population. We have 120 full-time employees, and our turnover is around 3 million euros. So, starting off, I would like to focus a bit on what we were trying to do. First of all, we were trying to prevent and protect our residents from infection. We were also aiming to promote good mental health, helping them to sustain their mental health, and to support those who either experience a relapse or those members of the public who start developing a mental health condition. We were also working very hard to ensure timely intervention, particularly as we shall see in the context of many changes in services. As others have mentioned, wards changed, the premises from where services were being offered changed, and for some time our clients were very confused and very anxious, not just about COVID, but also about where they were going to access their services. And we had a very important role there in trying to obtain the information and make it available to them. Until Christmas of last year, we had no infections. We were working very hard, no infections with clients or with staff. But from Christmas onwards, then it reached us as well. So we had a disruption due to the quarantine of staff, and parts of the program had to be halted. The reason why we didn't have infections is because all of our residences were under lockdown for the worst part of the pandemic in Malta last year. When the numbers were very high, our residences were on lockdown, and the staff were living with the residences. A number of meetings, nearly all the meetings shifted online or via telephone, although we still maintained face-to-face interventions when there was the need and in cases of crisis. We had to change some premises around, so all the vulnerable clients were accommodated in our biggest house with the largest garden so that they could be in lockdown in a suitable place. But obviously this caused them some disruption. With less staff on duty within the residences, clients had less support, and they also missed out on outings and leisure activities, which reflect what Eric was saying. So the things which helped their rehabilitation were also curtailed. We obviously found it more difficult to keep them looking for jobs and helping them to sustain their jobs. Increased isolation due to fear of infection and lockdown affected many of our clients. And as a result, we saw an increase in anxiety and in depression. Obviously, our clients could not meet their care workers daily because there were reduced staff to reduce the possibility of infection, and anxiety and depression increased in general. They also very much missed their contacts with their family members. And as a result of this, we saw a significant sadness among all our residents. One particular client also reported extreme sadness following having contracted COVID. We don't really know why, but this was something which really stood out. Once the lockdown was released, a number of our clients found difficulty regaining the routine, and that is where we had to empower them very strongly to venture out again and to start enjoying life outdoors. The symptoms of a number of people worsened, so there was increased frustration and anxiety and depression overall. Particularly clients with OCD, we saw that their symptoms became more pronounced, as well as with agoraphobia. And in both these cases, where all the therapeutic work, or most of the therapeutic work which we had done with them to help them to learn how to control their condition, were lost because obviously the increased washing of hands and the suggestions to stay indoors both affected these conditions. Lockdown for several weeks, awaiting swab test results was very anxiety provoking, and quarantine as well. We also realized that motivation was greatly reduced, and the staff had a tough time trying to keep clients motivated, even because whereas previously a number of people would come from the outside to organize lectures and activities, that wasn't possible. Over Christmas, they very much missed the Christmas activities, and that is what caused also motivation to reduce and the sense of we cannot have any fun. Most of them struggled with technology, and our role was also in that sense. So we tried to teach them how to access services through technology and how to keep contact with their relatives and friends through technology. From the general public, calls for help increased by 400%. So last year, the demand for our services was 4 times as much as it usually is. There were helpful elements, and these were indoor activities which we organized for our clients, going for a walk even in the garden when this was possible, and when lockdown was not like totally prescriptive, the staff would go for a walk with 1 or 2 clients just to introduce a bit of a variety into the day. Our pets, every house has a pet, and we found that they were very therapeutic with the clients. Our clients also enjoyed watching movies, gardening, keeping contact with friends, and working with the team members, expressing thoughts and emotions with the team members and with each other. The members who were living in the residences during lockdown had a lot of hard work, being there like for 3 weeks at a stretch. In fact, we are now supporting the employees who were actually in lockdown because it also had an impact on the staff's mental health. Use of outdoor areas was very much welcome, and the fact that the same staff were inside the houses was very helpful to the clients because they could attach better with the staff. The role of Richmond was mainly about bringing awareness about the pandemic and its effect, also with the general public. We aimed to promote ways how to protect one's mental well-being and also to explain to the clients the reasons for adjustments. Why are we in lockdown? Why do we have to stay inside? When they were on compulsory quarantine, some of them couldn't understand that they definitely couldn't go out, and that was our role. I'm saying, Jutta, I think I have to hurry up. Helping them to maintain a positive daily routine and helping them to retain flexibility in adjusting. We also partnered with the government to extend our helpline, which became the National Emotional Support Helpline and started to offer a 24-hour services. We're also running a research similar to what Eric mentioned across the Maltese population. We've had 8 surveys so far. We set up one house for all the vulnerable clients and a room in each house to enable prevention. Okay. We divided the teams into bubbles so that they wouldn't infect each other. We also had to shift all our training online. Our expenses increased remarkably. examples of good practice from Malta. We had regular briefing.
Stefania,
Yes,
could you
Okay.
finish?
I'll finish off here. So the availability of information was the basic, most encouraging and useful thing which Richmond employed during this time to support our clients. Thank you.
Thank you. This was quick. Thank you very much, Stefania, for these insights and for this perspective from Malta. We really learned a lot. Thank you again. And now it's time for the attendees to participate. And it's my great pleasure to introduce you to Nigel Olisa. He is the Executive Director of Gambian Europe, and he is in charge of the everyday activities of Gambian Europe. And today he has the task to guide us through the discussion so that all of you have the possibility, the opportunity to share with us your thoughts and maybe some questions. Nigel, I'm handing over to you.
Thank you, Jutta. Thank you everyone for participating in this event. I know it's everyone is zoomed out over the last year, but I'm hoping that at least you can give some contribution to this discussion that is being held today. Before I start, I would like to call on John Sanders. John Sanders is the Executive Director of UFAMI, which is a family member organization. I'd like to hear more from John about how things have been with the family organization. So John, interestingly, family and friends were the biggest source of support for many patients seeking mental health during this pandemic. So basically, I would like to know what has been the role of carers for mental health patients during this COVID crisis, and how has the pandemic affected their own mental health? Because we know carers are also vulnerable to getting mental health. Could you just maybe give us a little bit information from your members?
Thank you, Nigel, and delighted to be here, and thank you for all of the really good presentations that we've heard so far. And I'll say very briefly at the outset, much of what I've heard this morning is very familiar information, and it's nothing new. And I think most countries have experienced similar experiences across their own populations. What comes back to me from listening to what I've heard this morning and from talking to families in many different countries and many different organizations is that really what COVID-19 did was highlight the fact that where there is community care in mental health, as there is in most countries, obviously, what that actually means is family care. That professional care is episodic as required by an individual, and that's quite right, and that's appropriate. But when the person is not engaged in professional care, he or she, in most cases, is engaged with some family carer or family support. And as you say, and as the research has shown, family support actually holds up many people's wellness in the community. When COVID happened, I think it's fair to say that we didn't realize or consciously acknowledge, I suppose, that as well as individuals with mental health being very vulnerable, that their family carers were vulnerable because they were placed in a very difficult, isolated situation, obviously. For example, many family members report that before COVID, they already had some difficult relationships with their loved one. And as we know, in severe mental ill health particularly, relationships become fractured very easily. And it is difficult always to maintain a positive relationship. COVID, for all of the information that we have this morning, all the reasons we know about, families became isolated, were locked in, literally sometimes in terms of their homes, were uncertain, were not getting access to either statutory or voluntary support as carers, and therefore they found themselves in a very difficult situation of trying to manage something which was really exacerbated by COVID-19. I think as time went on, then there was other things that came into play. And I'm thinking particularly about some countries where people overlooked, governments, I think, overlooked the fact that there's a significant population of people with mental ill health who were more vulnerable than the rest of the population. Dan Chisholm talked about the mortality issue, and that's a real issue. People, and Gamian's research showed that many people with mental health problems have physical conditions which make them more vulnerable. And we all know those conditions. And like, families were very concerned about that because they realized that their son or daughter or their loved one was probably more likely to have a bad effect from a COVID infection than other people. And the state, in many cases, didn't recognize this when they were doing their vaccination priorities. I was very familiar of countries where they obviously vaccinated people with very specific conditions where they were more vulnerable, people with immune disorders and so on, which is quite right. But what they didn't see was the number of people with mental health problems. And to us, that's some sort of unconscious stigma or bias that wasn't recognized. Now, when we brought it to people's attention, yes, countries did respond. And I think now most people with mental health who are very vulnerable will be part of a priority group for vaccination, hopefully. I think the other thing that struck families is this issue of digital and physical contact. Obviously, many countries quite rightly responded to not having a physical mental health service by providing digital supports. And digital support works well for some people. It doesn't work well for many other people. And one of the things that I've been seeing coming through is countries talking about post-COVID, whenever this is all gone, that we will have more digital supports. And I suppose one of our worries is that some countries might try and develop digital supports to replace physical or interpersonal supports. We would argue that digital supports are good, but they need to be complementary to physical and interpersonal supports. We all know that mental health and mental ill health is developed by direct interpersonal relationships, whether it's with doctors, nurses, or other therapists and so on. So yes, digital learning is important, but alongside the interpersonal that needs to continue after COVID. So that's my initial comment, Nigel. Happy to give more if necessary.
Thank you so much, John. I think that's very comprehensive. We'll go talking about this digital health. I think we know that digital health is here to stay. It is the future. It's been adapted now, although we know that a lot of patients still do not have the digital savvy or do not have the gadgets or the facilities to be able to reach out to their physicians. So I would like to run that through Eric van der Eycken. Eric, I know you are a digital savvy person. You're an expert by experience, and you have been working a lot in the digital field for a while. Could you let us know exactly how patients are receiving this new digital technology area within mental health?
Yeah, thank you, Nigel. Yeah, I'm a little bit digital savvy, but I'm not a computer specialist. Anyway, I've been digging, since a long time now in the what you could call the e-mental health systems or technology, and to a great extent, I agree with what John said. There is, I think, e-mental health as such is not the solution for the mental health care. It is to be supplemental to the in-person healthcare. And I've written a few articles on that as well, because there are some, when you go to e-mental or to mental health care, let's say, it is interpersonal, yeah. And we are still working with a screen when we go to e-mental, when we go digital. We're still working with let's say, artificial tools and not personal tools. So I don't think, or I strongly believe that the impersonal therapies, impersonal healthcare cannot be cannot diminish. It will stay there. We will need it for sure. But I also believe, on the other hand, is because of the long waiting lists for health carers, we have to find solutions. To cope with this problem of the long waiting lists, and maybe put some, what I would say, some intermediate therapy sessions to keep the patient on the level that he can keep on going to the healthcare as well in other points of time. So I can talk a lot about e-mental healthcare, but there is also a lot to do in this area. But once again, if we talk about mental health, it is something interpersonal, and as well as John said, also family, your loved ones. It is so important, and this you cannot replace by digital technologies. So there's still a long way to go, and I have seen presentations about artificial intelligence, and it's nice as well. I'm an engineer, technology, nice and well, but still that factor of the human being has to be there, and that cannot be avoided. I mean, it has to be there. That's from my point of view, Nigel.
All right, thank you, Eric. So I would like to now move on, because we have questions from the audience, and there's a question I would like Dan to answer, and that question has been on the screen for quite a while. So Dan, if you're there, there's a question for you from Humanisha. The question is, to prevent neurotic conditions becoming psychotic conditions over time, therapy is profoundly crucial. Why doesn't WHO incorporate talking therapies to help all individuals with themselves with their mental health? Dan, are you there?
Yeah, I'm here. Can you hear me okay?
Yeah.
Yeah, thanks, Nigel, and thanks, Himani, for the question. In short, we do. We do advocate and make available talking therapies. Now, when we talk about that, that's actually, I think, a whole range of possible interventions. So ranging from self-help, information and guidance. So, for example, WHO has been developing something called Self-Help Plus, and because of the COVID pandemic, we brought forward one of the products from the trials that were being conducted, and so you can find a stress management self-help guide, doing what matters in times of stress, and that's been translated into, well, gosh, many languages already in the region. So there's sort of self-help, but then we talk also about, psychological first aid, for example, and that may be particularly useful for providing, primary health care or first line helpers in being able to provide that kind of psychosocial support. And then as you go up, yes, people with, for example, anxiety conditions may well benefit from more structured forms of psychosocial or psychological treatment, moving right through to cognitive behavioral therapy and so on. So I think the point I'd stress is that, a bit like Jutta was saying at the beginning, we're all on this continuum. And when faced with adversities, some people are going to react and have a need for, more intensive or enhanced sort of support and care. And that includes psychosocial, but also psychological support and treatment.
Okay, thanks, Dan. I have just one question from me. We've obviously seen that COVID-19 has had a strong impact on mental health due to the link between mental health and many other concerns such as loneliness, economic uncertainty, physical health, etc. How does the World Health Organization plan to mainstream mental health considerations into other policy areas?
Yeah, it's a standing challenge and effort, I would say. I think the new situation, does, as I was saying, sort of provide more evidence of the need for more integrated approaches. So to some extent, it's continuing to hit the same drum and say, yes, we need to better integrate mental health into, for example, primary healthcare. But I think, there are also clearly new opportunities to go beyond the health sector. And I think that's the biggest challenge in a way, is to be able to reach out effectively to other sectors, including social policy and service. This is a constant issue in countries one goes to, is that there is still this fragmentation between the health and the social care services. And so I think there's still much work to be done to bring those together. And also rehabilitation, community, housing, employment, just because this is so obviously important and needed at a community level. So I think, WHO can help in this regard through its convening capacity, bringing together people from policy, from practice, from research and innovation. We have established a mental health coalition in WHO Euro, for example, which is precisely aiming to enable that kind of forum and that gathering of interested stakeholders to exchange ideas, but also plan things together rather than in parallel.
Okay, thank you so much, Dan. I will now move on to Stefania. If Stefania, are you there? Hi, Stefania. I have a question for you, and this is a question that I think I've posed in one or two places. So, what have been the main challenges faced by your organization, by Richmond, during the crisis, and what could government have done better to support your work?
Well, the challenges were significant because our services are wide-ranging. So we face challenges with our residents. For example, we had to buy all our PPEs. It would have been very helpful, and that increased our cost, which we then needed to fundraise for. So it would have been helpful had PPEs been made available to us. After all, our services are a continuum from the National Health Service because we accommodate people who leave hospital to live in the community with us. There was a shortage of service. Not sure that government could have done anything immediately. It's more of a long-term thing. Psychological support professionals are very limited in Malta, and it is something that we hope going forward will learn our lessons and increase the human resource in the sector. One of the issues which was ironic because a number of outpatient services used to be offered from the General Hospital in Malta. And we, as part of the mental health strategy, which we have in place, the idea was to shift those services into the regional health clinics. As a result of COVID, the decision was taken with immediacy. So one fine day, the services from hospital were stopped and the transition started into mental health clinics. But during that time, a lot of our clients didn't have the necessary information of when their next appointment would happen and where they would access the service. So a good move, because the timing was too abrupt, had a negative impact on our clients. And it took a lot of energy to obtain the information and to convey it to our clients and to help them remain contained until they awaited news of their next appointment and the location. So a bit more planning, although we do understand that in the context of a pandemic, everything happens from one day to the next, but it definitely had an impact on our clients.
Okay, thanks, Stefania. Yuta, I know I'm running out of time, but there's one question that I would like to ask all the panelists who just came in. And I think I will start maybe with yourself, Jutta. So there's a question that came from Veronica. Do you think the conversation right now around mental health will reduce stigma and increase funds from government in order to improve psychosocial care? I think that's a very good question that it would be great to have everyone from the panel, give 1 or 2 responses to it. So Jutta?
Thank you very much for the question. I'm a bit looking at the time, therefore I'm afraid we have to close now. Maybe one more comment on the issue of stigma. I think, of course, it always comes up when speaking about mental condition and about mental disorders. And hopefully, by doing more sessions like this and by disseminating the knowledge about mental health conditions, we all can contribute to reducing stigma, because of course this is one of the aims for the future, to be able to speak openly about mental conditions, and to speak about mental conditions should become as normal as speaking about a flu. Therefore, I'm really happy that we could manage to organize this wonderful event, and I'd like to take the opportunity to thank all the participants again for their great and terrific talks, and to thank you, Nigel, for guiding us through this discussion, which was really fruitful and really helped us to learn more and to dig a bit deeper into the insights you all have as experts. So thank you again very much. And now it's time for some final remarks from UFA, some final remarks which apply to the future. So we would like to strengthen that we must address public mental health challenges, not only during COVID, but as well for the future, by distributing timely and relevant information, by providing psychological and not only psychological support, and protecting all our human rights. Economic crises have been showing important impacts on mental health. So let's start working for improving mental health as soon as possible. Be active. We all can be active, from financial support to changing mental health and the whole caring system. Additionally, the health workforce needs greater attention and support. COVID-19 has increased stress and health risks for health workers. Many even died. Care for carers, therefore, must become a health priority. And I'd like to invite you to further events organized by UFA in cooperation with a variety of other partners from around Europe, so you have time to follow these sessions throughout Tuesday, and it would be wonderful to see you again at one of these sessions. Therefore, for me, it remains to thank you again, and maybe to build on something Dan said, that this pandemic offers as well new opportunities to move beyond the health sector and to include other sectors in the responses and in the caring. We know that stress and mental conditions feed off each other, and therefore I really would like to remind you that we are all affected, and we can all change a bit the next years and maybe how we treat each other in the future. Therefore, I'd like to conclude with something which is not data-based, but I'd like to conclude with a poem. Of course, it's not a poem from 2029, so apologies for my mistake, but a poem from 2020, and I quickly read over it. When this is over, maybe we never again take for granted a handshake with a stranger, full shelves at the store, conversation with neighbors, a crowded theater, Friday night out, coffee with a friend, life itself. When this ends, this pandemic, maybe we find that we become more like the people we wanted to be, we were called to be, we hope to be, and maybe we stay that way, better for each other because of the worst. And with this, I'd like to conclude our session because we all can contribute to better mental health. Thank you again all.
Thank you.
And now I'm afraid we cannot meet for coffee, but maybe next year. So it's time to leave, and I hope to see you